The first abstract is called Long-Term Outcomes of Children Born to Women with Systemic Lupus Erythematosus. The paper is by Dr. Vinet, Scott, Pinot, Clark, and Gordon Kladen-Bernatsky from McGill and the United Kingdom. And Dr. Vinet, I believe, is going to present the paper.
So I'm very happy to, is it functioning? Okay. So I'm very happy to present today the result of our work here in Buenos Aires.
Microphone for the speaker, please.
It's not working?
Is the microphone for the speaker ready, please?
Huh? Can you try now? Okay. Are you? Yes, it's working. So I'm very happy to present the result of our work today here in Buenos Aires. In lupus pregnancy, many different disease-related factors can affect the fetus. Although several studies have been conducted to evaluate fetal outcome in lupus pregnancy, very few have examined the long-term outcomes of children born to mothers with SLE. Therefore, we aim to determine if children born to women with SLE have an increased risk of specific long-term outcomes, including major congenital anomalies, cardiac conduction disturbances, and serious infection compared to control of which consisted in children born to women without SLE. To assess this, we identify all women who had at least one hospitalization for delivery after SLE diagnosis using Quebec Amnis database over a 20-year period. Quebec Amnis database covers all residents within the province of Quebec in Canada and includes approximately 8 million persons. And in Quebec, there's a universal healthcare system. Women were defined as having SLE if they had at least one hospitalization or 2 physician visits with a diagnostic code of SLE prior to or at the time of delivery. We also randomly selected a control group composed of women matched at least 4:1 for age and year of delivery. We then formed the exposed group, which consisted in children born live to SLE cases, and the unexposed group, which consisted in children born live to match control women. The outcomes were defined either based on hospitalization or physician visit with relevant diagnostic codes and were ascertained within the first year of life for major congenital anomalies and through to end of database follow-up for cardiac conduction disturbances and serious infection. We perform multivariate analysis adjusting for maternal demographics such as race, comorbidities, obstetrical complications including preterm birth, sex, and birth order of child. We also perform adjustment for maternal medication in a subsample of children born to mothers with public drug coverage throughout pregnancy, and this included approximately 20% of the exposed and 20% of the unexposed. Thus, we identified more than 500 women with SLE who had more than 700 children after diagnosis, and these women were matched to more than 5,000 control women who had more than 8,000 children. When we look at the maternal characteristic of the children, we see that mothers with SLE were similar in terms of education and marital status to control women. However, they had a slightly increased risk of comorbidities, including more hypertension, asthma, diabetes, and depression compared to controls. Regarding obstetrical and perinatal characteristics, children born to women with SLE were more likely to be of the male gender than controls, and this led to a 20% increase in the male to female ratio of children born to women with SLE compared to controls. And this result has just been published in this month's issue of Arthritis and Rheumatism. Also, unsurprisingly, mothers with SLE had more complicated pregnancy than control women with rates that were comparable to what have been previously published, including more preterm birth, premature rupture of membrane, preeclampsia, gestational diabetes, and thromboembolic events. Regarding the main outcomes of interest, Children born to women with SAD had a 30% increase in the risk of major congenital anomaly and a 4.5-fold increase in the rate of cardiac conduction disturbances compared to control. In the overall sample, we did not find an increased risk of serious infection in children born to women with SAD compared to control. However, in the subsample analysis restricted to children born to mothers with public drug coverage throughout pregnancy, in which subsample we were able to adjust both for obstetrical complication and maternal medication, we observed a more than 80% increase in the rate of serious infection in children born to women with lupus. When we look at the different predictors of serious infection in that subsample, we saw that in addition to SAD, the other important predictor of serious infection was preterm birth, with a 2.8-fold increase in the rate of serious infection. In that subsample, we did not see an independent effect of medication exposure on the rate of serious infection, looking at corticosteroids, antimalarial, and immunosuppressive exposure during pregnancy. The mean time to first serious infection was similar between both exposed and unexposed, and there was no difference in the type of serious infection observed both in exposed and unexposed, with the most common type being upper respiratory tract infection. For major congenital anomaly, the most common type in both groups were cardiac septal defects. However, children born to women with SLE had an almost 3-fold increase in the risk of atrial septal defect and a 2.3-fold increase in the risk of ventral septal defect compared to control. However, this result might raise the suspicion of detection bias, because we know that in antero-positive and or anti-LUPUS-positive pregnancy, women need to have routine fetal echocardiography, and this may lead to increased detection of cardiac septal defect in lupus pregnancy. Also, notably in our sample, 16% of children exposed in utero to LSD had a fetal echocardiography during pregnancy, compared to only 2.5% of unexposed children. To account for the possibility of that bias, to try to eliminate for that, at least for detection bias due to fetal echocardiography, we perform a sensitivity analysis excluding all children who had at least one fetal echocardiography during pregnancy. And doing this, so excluding all children with fetal echocardiography, either in the exposed and unexposed group, we saw that children born to women with SAD had still a significant increased risk of both atrial septal defect and ventricular septal defect, with the OR with similar magnitude to the analysis, including the overall sample. Regarding cardiac conduction disturbances, the mean time to first event was much shorter in exposed than unexposed, occurring most of the time in the exposed, the majority of the event within the first 3 months of life. Also, in both groups, the most frequent type of cardiac conduction disturbances were bradyarrhythmia, with more than 90% of the event in the exposed being bradyarrhythmia. We have to acknowledge some limitation. We were only able to perform the subsample analysis for medication exposure in the children with public drug coverage during pregnancy, born to those women, and this was only for the Alarcón serious infection. It has been very interesting to see the effect of medication exposure, notably on major congenital anomaly. However, the small number of events precluded this analysis. Also, we have to know that in administrative database research, there is no gold standard, so there is imperfect case assortment and also exposure assortment. So this may introduce imprecision in the estimate that we will further account using more complex model, notably Bayesian class model analysis. But in conclusion, we can still conclude that mothers with SLE have an increased risk of major congenital anomaly, cardiac conduction disturbances, and potentially serious infection. There seems to be a substantial increase in the risk of cardiac septal defects in children born to women with SLE compared to control that needs to be further elucidated. I would like to acknowledge all the co-authors, but particularly Sasha Bernatsky and Anne Clark, who have been great mentors. Thank you.
Thank you, Dr. Vinet, for your presentation. Now the paper is open for taking questions. Let me, Dr. Vinet, do the first question.
Okay, yes.
According to your data, do you recommend any specific protocol to the follow-up of the pregnancy in lupus patients?
No, because, in fact, we look really at the outcomes, and there's we will now evaluate more the use of, for example, fetal echocardiography during pregnancy, because we saw a significant higher number of that technique used, but and we'll assess possibly the cost associated with the pregnancy in lupus patient compared to control, because we have all the data, but we cannot from that extrapolate a recommendation for clinical use. We can, what is really intriguing is the cardiac septal defect, the increased risk that really needs to be further studied, because we thought initially that this could be associated with anti-Ro antibody. We don't have any serology in our study because it's an administrative database. However, by excluding all patients who had fetal echocardiography during pregnancy, it does not seem to be mediated by anti-Ro, because probably most patients that were anti-Ro had a fetal echocardiography, although about 20% of women were diagnosed with SLE during that pregnancy. So this will need to be further clarified.
How many of these actually required surgical repair? Because, number one, how are you diagnosing it just doing that? Or in many cases, these are completely innocent, have no meaning at all, and don't require surgical repair, and they're, completely, you lose the defect as one grows. It can be effective prematurity. So the real question is, what is the clinical significance, and how many had surgical repair?
That's it. So this is something that I don't have the answer right now, but we'll be able to look, because we have all the evolution throughout childhood of all the children, so we'll be able to see how many children had a surgical procedure following to that.
Okay, thank you very much, Dr. Vinet.